they did it for diabetic reasons.
Yep, that's right.
So
you could take it.
All that is eliminated when you get out of the stomach and start going to the intestine.
Yeah, that's another good question. Let's talk about that. So we'll get.
Just thinking about that.
Yeah, you good. Both are really good, and you're right on target on two different interesting topics. Okay, there's lots of people trying to fight obesity with surgery. And there's lots of choices. As you know, there's the lap band, there's the Roux-en-Y gastric bypass. I think we heard in clinic about the bilio-pancreatic diversion with duodenal switch. One of the new surgeries that's out there is something called the sleeve gastrectomy, where they cut the stomach a lot like mine, but no bypass. Okay, so one question that comes up is the mini gastric bypass has this long, narrow stomach that looks a lot like the sleeve gastrectomy, and it has a bypass. So you could ask a couple of questions. Dr. Rutledge, what happens if you just do a sleeve, just do the stomach part of the MGB? And we've done that, and I can answer that. And the other question, I think this is kind of what you were asking, is what if you left a big stomach and did a bypass? Okay, and we know the answers to all of those, and I'd like to touch on them and talk about them a little bit because they help you understand what we do with the MGB and kind of predicts what's going to happen, in my opinion, with the sleeve gastrectomy and some of the other types of surgery. Okay, when we see patients, we usually go in with the idea that we're going to make a narrow, small stomach, cut through the vagus nerve, and bypass some intestine. But sometimes we can't do that. There's been other surgery. There's other scar tissue, there's other abnormalities, and we can't do it. Sometimes we've actually had people lie to us because they want to have the surgery, and they will say things like, we had a lady from West Virginia who came and said she had surgery, and she had a big scar in the middle of her belly, and she said that was from a gallbladder. We said, okay, because we usually do that. We went in, and there was all this scarring around her stomach. And we took about an extra hour or two fighting through the scar tissue, and this seems like a strange place for scar tissue if somebody operated on the gallbladder, because that's on the other side of the abdomen. Well, in her case, we couldn't create the normal narrow stomach. So we just did a bypass. Okay? And she lost some weight, but not much. Remember, our average weight loss with a small stomach and the bypass is around 140 pounds. In her, with a pretty big stomach and a pretty big bypass, so only really half of the surgery, she lost about 50 pounds.
But it improved her diabetic situation.
Right, but she was 350 and she wanted more, and then after kind of talking on the phone, and there was actually some times of crying because she didn't get enough weight loss and she was very sad, she then admitted that she'd actually had a previous stomach stapling that she didn't tell me about. So all that scar tissue had kind of blocked our ability to get up there. So, but what we know from her and other people is that we can do half the surgery. We can do just the bypass and leave a big stomach, and that doesn't lead to as much weight loss, maybe less than half. We've also had the reverse situation. We've had people come to us, and we could do the stomach part, could make a narrow stomach, and we go to do the bypass of the intestine, and the bowel is all trapped in scar tissue. It's all wrapped up and scarred from the hysterectomy and the C-section, and maybe a colon cancer or perforated diverticulitis or appendicitis. And so when we go to get that intestine to bypass it, we find that it's all trapped in scar. So we have done about 100 patients in whom we just did the stomach. So the MGB has two parts. We did one half in about 100 patients, and we found they lost some weight, a little less than half. So if you put the two together, they give you a little bit more than both together. Also, it means since our half of our surgery, where we just do the stomach, is almost exactly like the sleeve, what we predict for the sleeve patients is they'll lose about half as much as us.
Because they're not cutting that nerve.
They're not cutting the nerve, and also they don't do the bypass.
Gotcha.
So in other words, we do the bypass understanding that in a perfect world you wouldn't have surgery at all. But when we do the bypass, we add a little over half of your weight loss comes from the combination of the two together. And that two pieces work together to give the power of the MGB. And we know, and this was your question, it's a really good one, we could do half, and we could do either half, and we have done half of both parts of the MGB, and we know that gives you a little less than half of the weight loss. So it's kind of interesting. And again, you had a very insightful question. You said, what if you're diabetic and you want the hormonal changes where your insulin is helped by the increase in the gastrointestinal peptide and the glucagon-like peptides? Could you do an MGB and leave a big stomach? And the answer is yes. And we've done that in a few of our diabetics now.
Yeah, they said they didn't have weight issues, but it made them, it's amazing. Why don't you do, how come diabetics don't get it? What's going on here?
Well, this is new. I mean, for a long time, we thought diabetes was incurable, and we thought that weight loss surgery was for weight loss. And now we're learning that maybe it affects these metabolic parameters. Remember, we were talking to her husband yesterday about cholesterol. You know, we could talk to people about sleep apnea because they're not always morbidly obese.
What is that? It's not snoring.
Well, snoring and sleep apnea are often together.
Okay.
What's that?
It's part of it.
It's part of it, right.
But
Okay.
sleep
But let me
apnea
finish here. I was going to
is-
stop that video. And no, that's a good question.